Thank you for the opportunity to present here today. My name is Claire Collins, and I'm a senior speech and language therapist in Our Lady's Hospice and Care Services. I'm presenting a case study today on behalf of both speech and language therapy and physiotherapy, and I hope it leads on from Rebecca's talk about interdisciplinary working. Just to give a bit of a background, speech and language therapists and specialist palliative care provide person-centred care as part of the multidisciplinary team through continuous assessment, advocacy and counselling, anticipating and responding to dynamic communication and swallowing processes in the context of a progressive illness. Whereas physiotherapists, on the other hand, make a difference to the quality of life of a person with a life-limiting condition by reducing common symptoms, pain, fatigue and dyspnea, and by improving their functional capacity to retain independence and dignity. This case refers to a female patient in an inpatient palliative care unit. She presented with motor neuron disease of spinal onset and was approximately 8 years post-diagnosis. She had long-standing dyspnea and used non-invasive positive pressure ventilation at night, but her daytime nippy use was also increasing because of increasing breathlessness. In the past 6 months, she had significant progression of her bulbar symptoms and presented with severe progressive dysarthria and a moderate dysphagia, which was further exacerbated by her breathlessness. This resulted in reduced participation in social interactions, increased breakdowns in conversation, and prolonged meal times. Her increasing reliance on her nippy mat, delivered via an oronasal face mask, provided an additional barrier to communication and to her eating and drinking. A holistic management plan had been co-designed with the patient to support her communication and swallowing. She had been introduced and engaged in a period of rehabilitation with an eye gaze communication device, but she was keen to continue using verbal communication for as long as possible, and that was important to her. In terms of her swallowing, she had reduced tongue strength, range, and rate of movement, and this impacted her ability to manipulate food in the mouth. She was again keen to continue eating her preferred foods as long as she could, and she was having a combination of a level 6 soft and bite-sized and a level 5 minced and moist foods. She had good insight into both her progressive dysarthria and her progressive dysphagia and the use of compensatory strategies to help, but her increasing dyspnea and fatigue was impacting both her mealtime and her communicative success. The key objective in this case was to explore an alternative method of breathlessness management with a goal of enhancing the patient's communication and swallowing function, to support her to continue to communicate verbally and to continue to eat her preferred foods and thus improve her overall quality of life. Patients with motor neuron disease typically use an oronasal nippy interface. As shown here, use of one of these oronasal face masks can severely impact a person's ability to communicate. Patients report muffled speech, reduced audibility, difficulty coordinating speaking with ventilator-assisted breaths, altered resonance, difficulty using eye gaze technology, and these difficulties are further complicated if a person is also presenting with bulbar symptoms, as in this case. This can result in increased anxiety, frustration, and distress due to communication failure, and results in decreased opportunities for social interactions. These types of face masks can also prevent eating and drinking. They can cause pressure sores and cause claustrophobia and change a person's perception of themselves because they're so visual on looking at the person. Mouthpiece ventilation, on the other hand, is a less invasive form of nippy, whereby a ventilator-assisted breath is self-initiated using a rigid mouthpiece straw. A support arm for the single limb open circuit facilitates positioning of the mouthpiece, which is really important, particularly in the case of somebody with motor neuron disease with upper limb weakness. The patient activates the breath by placing their lips firmly around the mouthpiece, and a small negative pressure is created in the circuit by sipping or inhaling. Patients can choose with every inspiration the amount of air they want to inhale, adjusting the mouthpiece seal with their lips. Here are examples of a portable home mechanical ventilator with a mouthpiece ventilation set up and the support arm there where you can see in the pictures. Mouthpiece ventilation is not a new interface, and it's been used as an alternative to mechanical ventilation via tracheostomy since about the 1960s. But specific equipment for mouthpiece ventilation has only become commercially available since about 2012. And since then, its use worldwide for adult and pediatric populations, particularly those with neuromuscular disorders, has increased. Its use in Ireland for patients with motor neuron disease has also increased significantly, particularly in the past 2 or so years. There are several benefits of mouthpiece ventilation. It's improved appearance, it supports communication, it facilitates eating, drinking, and swallowing, there's no risk of skin breakdown, and less risk of claustrophobia. As a speech and language therapy department, we identified increasing numbers of patients with motor neuron disease being admitted with mouthpiece ventilation set up. And we recognise the positive impact this was having on supporting patients' communication and swallowing. Our advice was being sought to support patients swallowing with mouthpiece ventilation in situ from the ward staff. So we arranged an in-service with the clinical specialist physiotherapist from Bowman Hospital's Motor Neuron Disease Clinic. And this was an opportunity to develop our professional relationships and also to increase our knowledge and confidence regarding mouthpiece ventilation and its assessment pathway. As a department, we considered potential outcome measures for identifying the benefit of mouthpiece ventilation on communication and swallowing. Just to give a bit of a background on the physiotherapy outreach service in Beaumont Hospital, in 2021, staffing resources were provided via modernised care pathways for a national motor neuron disease service, and this enabled the service to support and complement primary care and palliative care services. Their primary focus is on improving access to specialist respiratory assessment and interventions, for example, cough assist, and in this case, mouthpiece ventilation. In terms of the assessment itself, it focuses on two key areas. The first is the ability to lip seal, i.e. to suck through a straw, and the second is the ability to trigger a breath appropriately. One pressure is prescribed on a second nippy machine, and the pressure is started slightly higher than what's already set up for the inspiratory positive airway pressure on the oronasal nippy machine, and it's titrated upwards to comfort. A person puts their mouth around the mouthpiece and takes a breath in. The seal can be released once a satisfying breath has been achieved, and again, the patient has full control. Going back to the case itself, communication was made with the National Motor Neuron Disease Service and an outreach mouthpiece ventilation assessment was scheduled. Interdisciplinary teamwork ensured optimal mouthpiece ventilation setup, particularly important in the context of the patient's bulbar symptoms. Challenges were identified in relation to her lip seal in terms of positioning the mouthpiece clamp and her ventilator settings, but collaborative solutions are reached in order to maximise her independence and her confidence using mouthpiece ventilation and to ensure that she could still independently carry out important activities of daily living. For her, it was really important to still be able to drink her fluids independently by accessing her straw, and for the mouthpiece ventilation equipment not to get in the way of her doing that. Education was carried out with the patient, her family, and the teams on the ward. Quantitative outcome measures taken prior to and post-introduction of mouthpiece ventilation assessment demonstrated improved breathlessness responses for both speaking and eating. And quantitative outcome measures taken prior with and without the mouthpiece ventilation in situ demonstrated increases in phonation time, in vocal intensity, and in maximum syllables per breath. To give some additional context here, maximum phonation time norms for an average adult are about 15 to 25 seconds. A very loud voice is considered somewhere between 75 and 85 decibels, and average syllables per breath norms are around 16.55 syllables. In terms of the patient herself, she feels that she's accepting of the mouthpiece ventilation now as she can see its benefit. She doesn't feel as fatigued when she's talking with it. She feels it gives her a stronger voice, which is particularly important when there are a number of people in her room, as there usually is. And it helps to calm her when she's feeling panicky because of her breathlessness. The next steps moving forward for this patient, she's going to continue to engage in ongoing rehabilitation with speech and language therapy, focusing on continuing to support her mouthpiece ventilation use to facilitate communication and swallowing as her condition progresses. And when she's ready, she'll engage further with her eye gaze communication device at a time that's appropriate for her. She's currently exploring a new supportive seating system with occupational therapy as she's having increased difficulties maintaining her trunk position. And this will raise new issues requiring further collaborative working. It will be important to optimise her independence to move from reclined to upright position to enable her to continue to use her mouthpiece ventilation and drink her fluids independently. So she's going to trial a joystick function on her riser recliner chair, and the potential will be explored to look at eye gaze technology to control her chair as her upper limb function continues to decline. It will be important to continue to strengthen relationships between speech and language therapy and physiotherapy, to identify patients with motor neuron disease who might be suitable to trial mouthpiece ventilation, and to support those who are already set up with it. With workforce planning, there's potential to explore an on-site mouthpiece ventilation assessment service with physiotherapy and speech and language therapy, and this could reduce the pressure on the national service and facilitate integrated care across inpatient and outpatient settings. There was another community patient recently who was admitted who literally just been set up assessed for and set up with mouthpiece ventilation the morning he was admitted to the palliative care unit. So it could take some of the pressure off there. And it may be possible to explore mouthpiece ventilation with patients beyond those with motor neuron disease, for example, those with COPD or pulmonary fibrosis. It'll be important to build the evidence base for the use of mouthpiece ventilation to support communication and swallowing in motor neuron disease and beyond. And this case reflection, in conclusion, demonstrates collaborative practice between speech and language therapy and physiotherapy to optimize communication and swallowing in the context of respiratory muscle weakness associated with motor neuron disease. Interdisciplinary palliative rehabilitation, as we heard earlier, can lead to improved symptom management and quality of life in the context of advanced illness. But workforce planning, as we know, is imperative to ensure that a skilled interdisciplinary workforce is available to deliver this holistic palliative rehabilitation in the right place at the right time. And this case study demonstrates that mouthpiece ventilation can support communication and swallowing, can improve quality of life for patients with motor neuron disease, particularly those in the case of those with bulbar symptoms where it might be thought that it would not be possible to do so. Speech and language therapy expertise in speech production and the coordination of the respiratory, the phonatory, the articulatory and the resonatory systems, as well as swallowing function, can provide a valuable addition to this assessment. But further research is needed to explore the impact of mouthpiece ventilation long-term across a wider cohort of patients and with a broad range of medical diagnosis. Finally, we'd just like to express our gratitude to the patient who gave us permission to present her case today and to the large team involved in her care. Yeah, so the only research I could find that compared both was in the cases of patients with muscular dystrophy, and they looked at both the nasal and the mouthpiece. Patients tended to prefer the mouthpiece over the nasal because they felt it improved their speech quality. It reduced the altered resonance from having the air go through their nose. They felt their speech was clearer. It gave them a louder voice, and it was easier from a swallowing perspective to coordinate the process of breathing and swallowing because they didn't have the ventilator-assisted breaths kind of just coming at them without being aware of it. They had control over them using the mouthpiece ventilation, so they could take a breath in when they were ready to do so with food or fluids in their mouth, whereas with the nasal version, the air would come when the mouth opened to take food into the mouth, or when the upper airway opened again after the swallowing process had been complete. And in the case of food residue or particles being left in the throat after swallowing, if that breath comes too early and the person's not ready for it before they've cleared, they found there's an increase of risk of aspiration there and more uncomfortable to swallow. So I suppose it's going to be, like some patients may prefer, it's trial and error. Our population in the palliative care unit tend to be set up more with the oronasal, the full face mask, which completely impacts their ability to communicate, and mouthpiece ventilation seeing, I suppose, as a daytime adjunct to that. But we're still going to have cases for sure of patients using the nasal versions.